So the following presentation will be on blood flow restriction training and a scoping review of the current literature as it sits as of right now in 2020. This presentation's audience is intended for Chapman University's Department of Physical Therapy program. Objectives of this presentation will include the following: blood flow restriction defined, the effectiveness of blood flow restriction locally and systemically, physiologically. We'll look at blood flow restriction under resistance endurance training, as well as the effects that it has on bone and neural tissues. We'll consider the safety and side effects, as well as the practical and clinical implications. We'll start off by defining what blood flow restriction training is with our first objective. Restriction training initially started in Japan. It was known as Katsu training. It's been around since the 1960s or so. In 2008, it came over to the States and since has been marketed by several different companies, of which we'll talk about Owens Recovery Science, Be Strong is another company, as well as Smart Cuffs. There's several of them out there. But essentially what this is training with a mnemonic tourniquet style cuff on the proximal portion of all limbs. It can be done with and without exercise in the form of resistance and or aerobic training. The pressures that usually almost always occlude the venous flow. There are some exceptions to this, and we can discuss. And there's a certain percentage of the arterial flow that will also be occluded. First, in the mode of resistance training. Okay, so start off with some general statements that are founded by the research. Exercise plus blood flow restriction leads to hypertrophic adaptations with much lower intensity resistance than previously believed. The low intensity blood flow restriction hypertrophy is consistent with that of moderate to high intensity exercise or resistance training. Okay, so the next couple slides, I'm going to present two meta-analyses, one in 2012 by Jeremy Lenicky, the other one in 2016 by Slees et al. Okay, so I'm going to start off with a couple meta-analyses so we can get a sense of what the pooled data has to say. Additionally, I'm going to present a number of different resistance training articles where blood flow restriction has been applied in comparison to low intensity resistance training, high intensity resistance training, as well as no occlusion or no exercise at all. And so I'm going to kind of go through these relatively quickly. The sources are there for if you want to go more in depth with each of the studies. So first, Jeremy Lenicky and his group at the University of Oklahoma are really big into the BFR research, and they've done a lot of evidence-based systematic reviews, as well as looking at the mechanisms behind BFR and how it actually produces the effects that you're about to see. So if you're further interested, that's another research group that you can consider. So this is low intensity blood flow restriction training meta-analysis that came out in 2012. 11 included studies were Okay, and I've given a graphical representation of their findings. On the y-axis, you have the effect size. On the x-axis, you have BFR and exercise. Exercise being low-intensity resistance training at 30% 1 RM, comparable to the same intensity used with the blood flow restriction training. The effect size of 0.39 is considered a mild to moderate effect size. It is also considered statistically significant within their findings. And this is, again, for hypertrophy. If we're looking at muscle strength, there's even a further effect size, and you can see that there's really no resistance training effects on strength at 30% 1 RM. However, in the presence of blood flow restriction training, there is a significant moderate effect that is statistically significant. Okay, the conclusions that Lenicky and his group came to within this meta-analysis: BFR resulted in significant greater gains in strength and hypertrophy when performed with resistance training or walking. So they also included walking. We'll get to the blood flow restriction training, as well as in the presence of aerobic training in slides to come. But they also included those studies within this meta-analysis. The low intensity BFR 2 to 3 times per week is just as good as that of 4 to 5 times per week of BFR. Thus, you can do it 2 to 3 times per week to get the maximal effect of strength and hypertrophy. So I think these next couple of diagrams really help to look at the timelines of BFR and the hypertrophy as well as the strength effects. So again, here you have the effect size on the y-axis. You have the timelines shown there at the bottom. So strength consistently from 4 weeks to 10 weeks has a consistent effect size. The hypertrophy does take a little bit longer to take effect, and it has a higher statistically significant change between weeks 8 and 10 versus weeks 4 and 8. And again, this is consistently more than that of the low intensity exercise that it was compared. Okay, so this is a good diagram. It's a little busy. I get it. On the y-axis, you have progress or adaptation of tissue. On the x-axis, you have time. And so we're going to compare low intensity BFR to traditional resistance training and the adaptations of the tissues and the said timelines. So first, looking at hypertrophy, you can see that there's a significant increase exponentially for the hypertrophy of low intensity BFR, much more rapidly than that of traditional resistance training. If we now look at strength, we actually see an opposite effect where the traditional resistance training actually rapidly increases in respect to that of the strength, the low intensity blood flow restriction strength adaptations. And then in comparison to the neural adaptations, very similar to that of the strength, we can see that the neural adaptations of traditional resistance training rapidly increase compared to that of low intensity BFR. Thus, the take home really here is the fact that traditional resistance training, if plausible, is going to be better for strength and hypertrophy in the long term. However, if someone cannot otherwise tolerate the traditional resistance training or resources are not available to actually load someone at 65 to 75% of their 1RM, which is the lowest amount of load that is been shown to actually create a hypertrophic and or strength gain, then it's recommended that there may be an opportunity here with the blood flow restriction. And there's still more debate being had as to whether there can be an augment effect if these traditional resistance training is combined with low intensity. Okay, a second meta-analysis. So this is shown in the form of a forest plot. You can see in that first diagram that muscle strength, that there is a relatively low but consistent positive effect that favors low intensity BFR in the form of strength when in the form of resistance training. Additionally, with the muscle hypertrophy in that second diagram to the right, you can see that the low intensity BFR consistently also wins out when pooled. And this is a much larger meta-analysis. It's more up to date as well, as it was done in 2016 compared to the 2012 Lenicky that only included 11 studies. All right, now we're going to go into, again, several different studies that kind of shows you the different formats, the different demographics at which blood flow restriction training has been applied. I'm going to really kind of target you in as to what I hope that you get out of it is rather the broad picture and the scope of blood flow restriction training and the current literature, rather than diving too deep into the methods at this time. By all means, I've hyperlinked the resources, and you can look at those more in depth in your time. Okay, so the next two studies are going to look at the comparison within the same individual, comparing one arm to the other arm. One arm will be restricted with BFR, the other one will not. We'll look at one example in the upper extremity and one example in the lower extremity. Okay, so here's the first example by Patterson et al. In 2009. They had 16 female subjects that did plantar flexion. They had two cohorts. One was restricted and one was not. And when I say cohorts, I mean they had one limb that was restricted and one that was not. Some limbs were randomized into a 25% 1RM versus a 50% RM. They did a duration of 4 weeks, 12 sessions total. They did a standard cadence of 1.5 seconds up and down. The isokinetic dynamometer was used for strength outcomes, and the blood flow pre and post was also taken. Okay, so within a 4-week time frame, we can see that there's a statistically significant and meaningful difference from the normal or the non-restricted limb compared to that of the restricted limb, whereas the restricted limb had a 26% increase in the amount of 1 RM within a 4-week time frame relative to just plantar flexion strength alone. When you look at isometric max volitional contraction, same story. This time that the difference was much more drastic, as there was a 106% increase in the MVC compared to that of the non-restricted limb. Keep in mind, these are the same individuals. We're simply comparing the limbs of the restricted limb versus the non-restricted. Here this is actually really quite interesting standpoint because here it actually shows that after 4 weeks, 12 sessions of blood flow restriction training, we actually see that there's a 43% increase of blood flow in the restricted limb compared to the non-restricted limb, suggesting that there's angiogenesis taking place in collateral perfusion within the calf muscle. This has implications for tissue healing, as blood supply can be extremely helpful in bringing nutrients and oxygen to healing tissues, tendons, ligaments, etc. Okay, similar study in the fact that it compares one limb to the other. One is occluded, one is not. These are females, 47 to 67 years of age. They're untrained. There's 11 total. I'm sorry, there's 24 total. In the BFR cohort, they had training with low intensity BFR. In the opposite limb, they compared it to high intensity upper extremity strength, which is considered in this study 80% of 1 RM, which we know is above that 65% threshold for hypertrophy and strength gains, and then the low intensity at 50% 1 RM. They also had another group that just did low intensity on both arms, on one arm, and then high intensity on the other. And then they had the no exercise controls, 5 individuals. 16 weeks, 32 sessions, 2 times a week, elbow flexion, just bicep curls. So the BFR was a 110, 10 centimeter width, duration 5 minutes, and they did 3 sets, 1 minute rest in between each set. The volume was tracked in reps times load. The low intensity group, whether they were restricted or not, were consistent. And then you also had the high intensity was otherwise consistent between the low intensity BFR group that was not restricted with their high intensity trained arm compared to that of the group that had high intensity but no occlusion. Okay, and then same outcomes or similar outcomes, MRI, so you're looking at cross-sectional area, and then isokinetic dynamometer for overall strength. So the results here for change in cross-sectional area are shown. And you can see that in red is your low intensity BFR, in yellow is your high intensity resistance training, and then in the blue is the low intensity group or limbs. And this really stood out to me from the standpoint that the cross-sectional area changed not only in the muscles trained, but also in the collateral, in the antagonistic triceps. And this was statistically significant. The low intensity beat out not only the high intensity group, but also the low intensity group with the triceps, which is quite interesting, and we'll talk more about that. But it makes sense that for the high intensity group, if you're just doing bicep curls, that why would the cross-sectional area of the triceps necessarily significantly increase? However, with the mechanisms at play for the low intensity BFR, that's exactly what we saw. Okay, and then the effect size of the cross-sectional area, we can see again is that the low intensity BFR group has a statistically significant difference compared to low intensity. There is a change here as far as the strength compared to the high intensity versus the low intensity BFR. The following studies are going to focus on post-operative use of BFR and the effects that it has. Before we get into that, the first study that I'm going to show is the response of the quadriceps in healthy individuals. So we have a baseline as to what you can expect, and then we'll look at the involved post-operative patient. Okay, Takaranda in Japan in 2004 looked at 18 healthy males. Low intensity BFR, low intensity, and no exercise were the groups. The subjects were evenly randomized into each group. 8 weeks, 2 times a week, a knee extension with a standardized tempo. The blood flow restriction cuff parameters are shown there, 218 millimeters of mercury, 9 centimeter cuff. The duration was 10 minutes. They did 5 sets to failure. Low intensity BFR was 80%, 1 RM. Okay, so cross-sectional area, these results kind of speak for themselves. So there was a 10% increase in the quadriceps in the low-intensity BFR, none compared to the low-intensity BFR or the no exercise. Okay, quadriceps strength, similar result. There's almost a 10% increase and approximately a 3% increase in muscle strength pre and post. You can see again, statistically significant, the low-intensity BFR group wins out. Okay, so now that we've seen what it looks like in a healthy population, let's compare that to the post-operative knee group. So you have 20 subjects, 10 BFR, 10 controls, 12 sessions, 6 weeks, 2 times a week. They did leg press, leg extension, and kickbacks. The intensity was 30%, 1 RM. They used a 4 sets a rep scheme, 30, 15, 15, 15. The rest was 30 seconds, and exercise rest in between the exercises was 1 minute. So you can see here that the girth statistically significantly improved versus that of the non-occluded controls, not only in the calf, but also, or not only 6 centimeters proximal to the patella, but also 16 centimeters proximal to the patella. Okay, so here is a representation of the growth hormone response in the plasma pre and post for the low intensity group as well as for the low intensity occluded group. You can see 15 minutes into the occlusion that there's a statistically significant difference not only between the occlusion and the low intensity group, but also of the occluded, just the occluded state. Okay, peak torque. Here you can see that there's a statistically significant difference with the occlusion versus the non-occluded. 74% increase in the occluded group, 33% increase in the non-occluded group. Right, post-operative, this is significant, right? Within 8 weeks, if you can get a 75% increase in the knee extension torque, that's huge. And then again with the knee flexion, you can see that there's a 20% increase or almost a doubling there of the knee flexion. And I did the calculations for you, so 41% increase compared to standard treatment, and then in the knee flexion of 5% increase. If you're asking these individuals on the COOS how they did, again, statistically significant across the board for every question for the BFR group. For symptoms, ADLs, and quality of life, the controls did not meet statistically significant difference from their pre, and their stair climbability also suffered. Okay, let's look at OTA in 2003. This is post-op ACL. So you have 44 individuals, occlusion and non-occluded group, females, 14, 10, 29 years of age, 16 weeks. 180 millimeters of mercury for the operative lower extremity. Post-operative ACL protocol was done for this exactly the same for both groups, with the exception that one group was occluded and the other one was not. The results are shown here. You can see that knee extension muscle strength for the restricted group. You're looking at a percentage from one limb to the next, so you can see that there's almost 20% increase on the restricted versus the non-restricted, and then for the knee flexors, that there's also statistically significant difference between the two. Okay, so one of the things that has been interesting is the combination of the modalities of NMES with blood flow restriction training. And so this is a post-operative study that looks exactly at that. So you have 20 individuals, females and males even, 29 years of age, controls. Then you had BFR, you had one that did NMES, and you had one that did a combo. So 6 weeks, 4 times a week, 200 millimeters of mercury for the cuff parameters. You had 2 electrodes. You can see the amount of stim that they received, as well as the parameters of wave frequency, etc. And here's essentially a diagram of how they incorporated. So the NMES was continuous throughout these 32 minutes. And then the cuff was inflated to 200 millimeters of mercury every 4 minutes. It was either inflated or deflated, etc. And the results here show that there's actually an aggregate effect with the combo group. So when you combine NMES and BFR, it's better than either of one of those alone when it comes to muscle strength. In hypertrophy, it really didn't matter whether you did BFR, NMES, or both, but you better do one of those because all of them are better than the control. Okay, so this is also something interesting, right? So let's look at muscle preservation and the arthrogenic muscle inhibition effects that surgery has on it, and how BFR can help us overcome these deficits. So Kubota, 2008, 15 males, they had 5 controls, isometric group 5, no exercise BFR group 200 millimeters. No mercury. And so they essentially what they did with these individuals is they casted them and said you can only walk on crutches. They are otherwise healthy. And so they did no exercise whatsoever, with the exception of that one group that did isometric, and then the BFR group that did no exercise at all. So the BFR was done 5 times for 5 minutes, for 3 minutes, 2 times a day, whereas the isometric group twice a day did isometrics that included the knee extension, knee flexion, ankle plantar flexors. Intensity, so they did for twice a day, the isometric group did 1 set of 20 reps with 5-second hold, with the BFR did none, except for just sit there and occlude their blood. Let's look at the. Okay, so here are the results. And you can see on the y-axis you have circumference of the muscle loss. So this is the immobile, you're looking at the muscle loss of the immobilized limb. You can see for the control group, not surprisingly, shown by the asterisk, is that there's a statistically significant difference in more muscle loss in the control group. Second to that is the isometric group, also had additional muscle loss. You're looking on the different areas that you're looking at are 15 centimeters proximal to the patella, 10 centimeters proximal to the patella, and then the thickest portion of the calf. And you can see, regardless, that across each of these locations, that the BFR group consistently won out, even though they did not do any exercise more than the controls. And where it counted the most, you can see that the BFR group was statistically significant for both groups in the calf, where the immobilization actually occurred. You're looking at the percent strength change in eccentric and concentric as measured by an isokinetic dynamometer. On the y-axis, you have the percent change in strength pre and post the immobilization. So you can see eccentrics at 120 degrees, eccentrics at 60 degrees, concentric at 60, and then the concentric at 120. And across the board, statistically significant, the BFR also preserved the muscle strength in relationship to each of the other groups. Okay, and here's another representation of that in the knee extension strength changes post the immobilization. And same story here, right? In each of the groups, the BFR group consistently won out. You got knee flexors, same story. Okay, so in fact, the same authors did this again. The one exception that they made is that they reduced the amount of occlusion. So they only occluded 50 millimeters of mercury. That was the pressure, which is for the lower extremity extremely low in regards, in respect to blood flow restriction training. And they controlled it. They compared it to 5 controls. It was 2 weeks. The frequency of the occlusion was 5 times 5, 3-minute rest, 2 times per day, no exercise. All subjects were immobilized with the left leg or left ankle, cast, and crutches. You can see again the specific parameters there of the BFR. Okay. Very similar results, even with a lower amount of BFR occlusion, right? So you had, you're looking again at the same outcomes, thigh 15 centimeters proximal to patella, thigh 10 centimeters proximal to the patella, thickest portion. Okay, here you see the outcomes for knee extensor strength pre and post immobilization. And though the effects were not statistically significant with the exception of eccentric at 60 degrees, there was across the board preservation of the muscle strength in relationship to the control. However, it was not statistically significant. A little bit more drastic as far as the knee flexors here, where you had statistically significant improvement in the eccentric 60, the isometric, the concentric 60, and the concentric 300. Okay, before we kind of wrap up this muscle preservation section, we're going to look at a post-op ACL group. So 16 individuals, they were randomized into 8 controls, 8 BFR, age 23, 2 weeks. The BFR parameters are shown there. They did not do any exercise for the first for the first 2 weeks. You can see that the occlusion occurred 2 times per day, 5 sets, 5 times 5 minutes, 3-minute rest in between. On average, you can expect 25 to 30% atrophy of the quadricep within this time frame. And so what you see in the experimental versus the control group is exactly that. So you can look at the, I drew the red line there so that it can kind of show the difference. When you're looking at total cross-sectional area in the black, and then you look at the quadricep where there's a significant difference that is shown between the quadriceps, where the control group predictably lost 22% approximately atrophy or cross-sectional area of their quadricep, whereas the experimental group, the BFR occluded group, did not. So only 9% decrease, right? It still sucks, but it's better than the 22% or the 20 to 30% that is expected. And keep in mind that they did not do any exercise different than the control. It was simply occluding their blood. And so there's 120% difference there between the occluded and the non-occluded. Okay, aerobic training. Just like the resistance training, I started off with systematic reviews. So it gives you a pooled analysis of what the effects are of BFR in the presence of aerobic capacity and performance are shown. So Bennett in 2019. Okay, so the results are shown here. Blood flow restriction training in the presence of aerobic exercise increases the measures of aerobic fitness and performance in younger adults when the occlusions are greater than 130 millimeters of mercury in the lower extremities. In older adults, measures of aerobic performance improve, however, the measures of aerobic fitness remain unchanged. Their definitions of aerobic performance are time to exhaustion and 6-meter walk test, the exact clinical parameters and outcomes that we look at in our older older adults, so that is good that the performance actually does improve. However, the fitness, on the other hand, the VO2 max does not improve in our older adults. That's clinically less relevant, usually in our older adult population. Okay, you're familiar with this study. It was the same systematic review that was shown in the resistance training set. Again, they used forest plots to demonstrate the difference in low intensity BFR in the presence of aerobic fitness improves muscle strength and muscle hypertrophy in comparison to controls. Okay, Abe in 2010, they did 19 subjects, 10 BFR, 9 controls, 8 weeks, 24 sessions, 3 times a week, cycling at 40% VO2 max. The BFR group did 15 minutes per session. The control group did 45 minutes per session, 3 times as longer, which equated to an aggregate of 12 hours more of cycling for the control group. And let's see what the results are. Here are the results. So on the y-axis, you have percent of cross-sectional change. The thighs, 3% increase. Quadriceps, 4.6% increase over that time frame. Again, the group that is shown with the greatest percent change in muscle strength in both the thigh, in cross-sectional area, biked for 12 hours less. Okay, and then if you look at the cross-sectional volume, which is different than the area, right? Because we're taking the volume, right? So back to your geometry. Then in the y-axis, again, same results, and you can see that there is little to no change pre and post these 8 weeks, these 24 sessions for the aerobic group. Okay, when you're looking at VO2 max, there was again a change plus 6.4% for the BFR group in as far as their exercise time, 15.4%, and that's exercise time to exhaustion. So again, it's actually really startling, right? So 12 hours less of exercise, yet this group consistently prevails in every outcome. Okay, so this group, Thomas in 2018, this is a more recent study. So 18 individuals, they took them on a Velotron cycle ergometer as shown in the picture to the right. The warm up 7 minutes, VO2 max 30%, 3 rounds, 2 minutes work, 2 minutes rest. The cool down as shown there, and they had a low intensity group, a BFR group, and they also had the high intensity group. Keep in mind that the BFR group was occluded at an individual occlusion pressure of 80% arterial occlusion. And what I did here was I actually looked at I mapped out the hemodynamics that they looked at. So this is you looking at just systolic. I highlighted the BFR group, and you can see that the high intensity BFR group for systolic blood pressure is consistently higher across all exercise time periods. The one difference is the diastolic. So diastolic for the BFR group does increase over the baseline, over that of the low intensity group, as well as the high intensity group. Implications on the MAP, or the mean arterial pressure during the exercise. And so you can see that the BFR group does increase in their mean arterial pressure more so than high intensity or low intensity group. The low intensity interval cycling can increase metabolic and cardiovascular demands compared to low intensity cycling alone. Increases in MAP with the low intensity BFR trials leads to increased myocardial workload greater than high intensity sessions. Use caution with a vascular compromised population, hence the increase in both the resting the diastolic volumes or diastolic pressures compared to the high intensity groups, as well as the MAPs. Okay, so next we're going to talk about the geriatric population blood flow restriction training, because this is one population where the risks may be a little bit higher, and even some clinicians have argued that maybe it's even contraindicated for this patient population. Okay, so starting again with the pooled analysis, looking at systematic review and meta-analysis from 2019. 11 included studies over 2,500 subjects. The results are previous surveys and reviews reports an acceptable level of safety of low-intensity BFR for mixed age populations. We recommend a thorough screening and physical examination of all trainees before commencing in this training regimen. And when you're looking at the effects in this older adult population, you can see that strength, when you're looking at high intensity loads versus low intensity loads of BFR, that for strength in this patient population actually wins out. However, you need to make sure that their high loads are 75 to 85% of their 1 rep max, which I would argue, at least in my experience, I haven't seen done consistently in the clinical setting. And then the low intensity BFR is 20 to 30% of the 1 RM. And this is what it looks like with an effect size, favoring the high load group. Hypertrophy. We can see that this actually favors the BFR group. When we're looking at strength in older patient populations, comparing low load, less than 50% 1 RM compared to the 20 to 30% 1 RM of the BFR group, strength wins out. Effect size 0.86, that's moderate to high effect size. Statistically significant. Strength with walking in BFR in this patient population, we can see that there's a significant increase pre and post for strength. In here, when we're looking at muscle mass or hypertrophy, we can see once again that there's a statistical significant difference between the walking group and that of the BFR, with the BFR significantly surpassing it with 3.1% improvement between the pre and the post when pooled. You can see also the parameters that were used with the hypertrophy studies, that the individuals were working at 45% heart rate reserve, 20 minutes 4 times a week for 10 weeks. And then the conclusion of the study was the additional low-load BFR resistance training or walking is an effective exercise alternative for older populations for whom traditional high-intensity training might be contraindicated due to comorbidities or high mechanical stress to bones and joints. Branching out from the musculoskeletal adaptations of blood flow restriction, let's look at its effects on the neural population. Specifically here, this example is Parkinson's disease. So though it's only a case study, I think it's a pretty strong testification as far as the potential that BFR has for this population. So a single subject, 10 weeks, they did a crossover trial. First week was used with BFR, whereas the last 4 weeks, no BFR. And the interventions otherwise stayed the same. It was five sets for 2 minutes, 1 minute rest in between, 3 times a week, treadmill walking. The pace is standardized below, as well as the millimeters of mercury that the cuff was set at. In this table to the right, you can see the different weeks, 1 through 6, the heart rate that was used or that the individual had during the exercise, their RPE, as well as the peak weekly blood pressure that the individual had before or while exercising. Okay, so here are some of the outcomes when you're looking at the timed up and go. You have on the y-axis seconds. The lower time obviously means better improvement with the timed up and go. And for the first 6 weeks, you can see on the bottom that that there's a line bifurcating the time points or weeks in which the individual is using BFR versus when they were not, between 6 weeks and 10 weeks. You can see that there's actually a gradual increase in the amount in the performance of TUG, meaning there's actually a regression in their performance, even though the interventions remain exactly the same with the exception of BFR. You can also see that same reduction with with the sit to stands. Again, repetitions, number of repetitions here on this outcome, more repetitions is the better. You can see that there is a statistical significant improvement during the first 6 weeks, and then preservation of their performance for 2 weeks, and then there was a gradual reduction by the 10th week. 6-minute walk test, very similar outcome that you can see here, that again, more distance shown on the y-axis is a better outcome for 6-minute walk test. You have on the x-axis you have weeks. For the BFR time points from weeks 0 to 6, there's a gradual increase in the performance, and then there's a reduction thereafter once the BFR is removed. Same thing with the RLS scale. So the RLS scale is a restless leg syndrome scale. This is one of the questionnaires that is used within the Parkinson's population and has been validated with that demographic. Weeks 0 to 6, there's a gradual reduction, which is a actual improvement on the RLS scale. And then there's again a 2-week preservation that was consistent with the tug as well as the sit to stand. And then there's the reduction or the regression after the BFR was removed. So I think that's a pretty strong testimony as far as the potential that BFR can have. Granted, yes, it's only one trial, it's a case study. However, there are more trials currently being performed with the neurologic population and blood flow restriction. Okay. Another consideration here is what's happening to the tissues as it obviously has effects on the strength, their hormones, as well as the tendons and contractile units. Seem to have an effect with blood flow restriction. So this was the information coming from a systematic review in BITAR 2018. You can see that there was 4 included studies with the author's name in that first column. The study sample size 18, 9, 37, 30, so relatively smaller sample sizes. Again, blood flow restriction has only been in the States since 2008, so I expect that additional research will be coming on this and the effects that bone remodeling will have in the presence of consistent blood flow restriction training. The interventions are shown there as well as the conclusions. So the conclusions, aerobic training combined with BFR increases the level of BAP, which is a hormone that is responsible for an indication of increased bone remodeling. Low intensity BFR combined with BFR decreases the metabolism during an acute bout. And then the low intensity short-term goal significant changes in the bone ALP, concentrations, and bone ALP. Again, these are hormones and biomarkers that are used to demonstrate a positive improvement in the bone remodeling process. Okay. Cross-education and the effects that blood flow restriction can have. So cross-education, for those who are not familiar, is essentially where you train one limb and you get adaptations on an untrained contralateral limb. In this case, they actually there have been some studies that have looked at training of the lower extremities and the effects that BFR has on the upper extremities. And so this is kind of demonstrated in that diagram there. Okay, so first study, Bowman, 2019, very recent study, 26 individuals, healthy, 27, a relatively even split or so between the males and females. The controls were 10, the BFR group was 16, one limb BFR, one limb no BFR. They did it for 6 weeks, 2 times a week. The exercises were ASLR, side-lying hip abduction, long arc quad, and standing hamstring curls. The volume and the intensities are shown there. So 30% 1RM with a rep scheme of 30, 30 seconds rest, 15, 30 seconds rest, 15, 30 seconds rest, and 15. The blood flow restriction was 80% of arterial occlusion. The isometric group did 1 times 20 times 5-second contractions, and the isokinetic dynamometer was used for the strength, and the hypertrophy using limb circumference. So the outcomes here, you can see the BFR limb, the non-BFR limb in those same individuals, and then the control. And the double asterisk demonstrates statistical significant improvement over both, and then that single asterisk over the non-BFR group in the thigh it also represents a statistical significant difference from the control. And so on the y-axis we have percent pre and post change in limb circumference. The first block of columns you can see is labeled by the thigh, the thickest part of the thigh, and then the calf, the thickest part of the calf, and consistently not only within the BFR trained limb but the contralateral limb showed to have additional increases in circumference relative to the controls who are doing the same program. Okay, so knee extension and flexion. So now we're considering strength. You can see that knee extension strength statistically significantly improved across for both the BFR limb and the non-BFR limb. Yes, there's improvement in knee flexion. However, it was not as significant as it was. It didn't meet statistical significance as it did with the knee extension group. Okay, hip extension and hip abduction. So the significance of this is it's not surprising, right, given the other findings of the study that BFR group and the non-BFR limb continually went out. However, these are muscle groups that are proximal to the cuff, which doesn't necessarily have the same mechanisms at play that affects the strength that you would think that those muscles that are actually getting the hypoxic event or stimulus, as we know from the mechanisms of BFR. But same story here, hip abduction, hip extension significantly improve in the BFR limb, and then the non-BFR limb consistently are outdoing the controls. The plantar flexion peak torque, same story. All right, and then the conclusions, right? So low BFR training produces a substantially greater increase in strength, both proximal and distal to the cuff placement, which speaks to not only the local but also the systemic effects that blood flow restriction has on the hormonal response as well as the nervous system to allow for adaptations in the non-trained limbs. The contralateral extremity may also benefit from the systemic or crossover effect, as we suggested. Another study, May et al. 2019 or 2018. Though I didn't present the studies on this, the specific findings on this, just due to lack of time and convenience. However, you can by all means see this study by clicking on the hyperlinked references at the end. So conclusion, lower limb BFR training increases training arm more than the contralateral untrained arm and the trained arm of controls. So the lower body blood flow restriction training may actually induce remote muscle strength and adaptations in the arm of the individual who does BFR in the lower extremities. So pretty impressed by this, and I think that these are more recent publications, as you can tell, and so you can expect that there'll be additional research to come out on this. All right, in summary, and kind of looking at the effects of BFR going forward, so blood flow restriction research is rapidly expanding. Patient demographics in which BFR research has been and will be applied include the postoperative upper and lower extremity, as well as total joint nerve injuries and muscle strains. Additionally, within the neurological patients with myositis, astronauts, of course, because they cannot use resistance to the mechanical tension of traditional hypertrophy and strength gains. Geriatric as well as adolescent studies are currently being conducted. This is one study that I did find quite interesting that also alludes to the fact that there may be more research coming out on this, as well as the effects for cognitive improvement that BFR can have. Again, in this study, they actually show or give better explanation as to the mechanisms due to back to the hyperhormonal response and the increased concentration there. Okay, so that's a bit about the safety and side effects. I tried to be relatively succinct in it. However, as you can see, that the information and the research out there is expansive. And so now we'll turn our attention to the safety and the side effects of. Okay, so I start off by looking at a very large study that looks at Katsu training, which is essentially the Japanese form of BFR, and that has been around for the last 5 decades, and so they have much larger epidemiological and pooled data. So Yasuda in 2017 looked at 232 clinics in Japan over almost 13,000 subjects. And then you can see that there's actually more females than males within this. However, we're now looking at the side effects and the most common side effects that were otherwise seen. So everything from cool feeling, numbness, subcutaneous hemorrhaging, where someone will actually gently bruise under the cuff. This can be also mitigated by gradually exposing their body to the BFR in the gradual increase in pressures over subsequent settings. Other things include pain, nausea, itching, hypertension was relatively low. One of the more common ones was anemia, where they would experience some of the same side effects there, headache, and others. Okay, so this was a separate study that looked at 3,500 different subjects between 2007 and 2013. Like that previous study, it was conducted in Japan, as there's much more data that has been out there. And this is the adverse events that they did find when using Katsu training. They did not specify as far as the screening that was done on these individuals. So the first is really unfortunate. A brain hemorrhaging did occur, comparable to sudden. The authors compared it to sudden cardiac death during an athletic participation. 35 years old, hypertrophic cardiomyopathy, cardiomegaly, coronary artery malformation, aortic rupture, brain hemorrhaging. These are all risks of physical exercise in general. However, they were not. It was unable to make the conclusion as to whether it was the BFR that actually, the Katsu training that actually caused it, or whether this was simply, again, the sudden cardiac or brain hemorrhaging that may have otherwise occurred. However, obviously there is a risk there, and if you take this study as well as the one previously presented just on the last slide, you can say that I guess brain hemorrhaging would be like 1 in 20,000 or so. However, we don't have any of the background data as far as whether this person was appropriate for Katsu training or blood flow restriction training, nor do we know whether this individual would have already had this event in the absence of the BFR. Okay, so venous thrombosis. So BFR actually induces a fibrinolytic state, aids in the restriction of thrombus in formation, meaning that it's actually somewhat beneficial, despite that you get the venous pooling that occurs within the limb. And then transient numbness. Again, the number reported was not specified. Rhabdomyolysis did occur in one individual. This is unfortunately. I don't quite understand the mechanisms here, because rhabdomyolysis is, as you may or may not know, is an excessive breakdown of muscle tissue and the effects that otherwise has on the kidneys, and it is a medical emergency. However, with blood flow restriction training, because there's actually with gradual exposure, there's less DOMS. There's actually less muscle tissue breakdown, which makes one of the reasons why BFR is really advantageous within an athletic season or prior to an athletic event, to prevent conditioning or detraining, while still maintaining and sustaining the strength gains and hypertrophy that someone has. However, rhabdomyolysis, given the high volume of the exercise, and it wasn't specified whether they were using the recommended 20 to 30% of the 1RM or what have you, but it did occur. Venous injury and induration also has occurred, number not reported. Usually those people are most at risk, females 30 to 50 years of age, spontaneous resolution within 1 or 2 months, repeated pressurization and depressurization to get like prior to doing the cuffs with exercise is recommended to allow the vessels to become accustomed to the additional pressures. And again, adhering to the Katsu training time or blood flow restriction time is similar. 15-20 minutes, no more than 30 would be highly recommended to avoid the venous injury and induration. Okay, so now looking within the states in actual blood flow restriction training versus going under the name of KATSU training, we find that there were 3 individuals. There was found in this case report that they highlighted as far as the effects. So scientific data indicates that the overall safety of BFR, at least in the healthy young population, is safe. Caution is thus needed in the application of BFR, and gentle familiarization with the training, as alluded to in the previous slide with the venous induration and potential injury, is recommended so that the venous and the vascular system can actually become accustomed to the pressures. So there have been a number of reviews that have looked at the safety of blood flow restriction training and its effects, side effects, and what populations are indicated versus contraindicated versus precautions. So we're going to step through some of these literature on a very large scale. So you have Domingos in 2018, 17. They looked at the effect of blood pressure during resistance training of greater than 60% 1RM. And you can see that there was the control versus the BFR, that the diastolic blood pressure did increase significantly more than that of the control. Same thing with the effect size during resistance training less than 1% 1RM. Systolic blood pressure dropped and diastolic dropped more than the controls thereafter. So yes, you may have a slight increase in the systolic and the diastolic during the exercise. However, this actually, your body in a healthy individual responds to that by actually decreasing your resting blood pressure thereafter, which can be somewhat advantageous. These time points are actually taken an hour after the exercise. It can be advantageous from the standpoint that if your goal is to gradually reduce the overall blood pressure, that there is an aggregate and long-term outcome on this, or a long-term effect, I should say. Okay, so here are the conclusions of the study. BFR at greater than 60% 1RM will result in increased diastolic blood pressure versus traditional resistance training. BFR less than 60% 1RM will increase both the systolic as well as the diastolic versus traditional resistance training. And BFR will result in greater systolic and diastolic decrease in hypertension and healthy blood pressure patients 60 minutes post-exercise versus your traditional resistance training. Thus, the authors go on to say that it can actually be used as a potential modality if done in the right individual with proper screening, that you can reduce some. Okay, and then finally, here's a quote from the conclusion. Resistance exercise with BFR should be prescribed with caution, especially with BP control during exercise is required and is necessary. Okay, looking at a recent study in 2019, effects of blood flow restriction exercise on hemostasis. So when we're actually looking at, I had alluded to in a couple slides before, how that blood flow restriction training can actually have a fibroanalytic effect. So this is an example of that. So we're going to look at, or I guess not an example of that, but this is when you actually look at a systematic review of that, of the results of that. So a couple of the blood factors that are used in these studies, or that are looked at, you have tissue plasminogen activation, or TPA, fibrinogen, FDP, prothrombin time, and D-dimer. You can see the definitions of each of them shown there in the middle column. I'll let you review each of those. And then you have the normal ranges shown there in the final column. Okay, and then here is the short-term conclusions that were made. Intervention of blood flow restriction exercise increased the fibrinolytic activity assessed by TPA measures. The data effectively supported the safety of BFR implementation for young, middle-aged, with stable ischemic heart disease individuals, or apparently healthy older adults. Okay, let's look at the long-term conclusions that were made. No long-standing significant effects indicating that blood clotting function remained unchanged in healthy subjects. Findings were supported in another investigating report that no adverse effects of BFR with low load resistance training, BFR with elastic bands, on FDP or D-dimer in older healthy adults. Okay, another systematic review here that looked at the hemodynamics. So 21 articles included. You have 16 articles that looked at blood pressure, 19 that looked at heart rate, rate of perceived exertion was included in 4. And this is a systematic review here. Hemodynamic changes, heart rate, systolic, diastolic, mean blood pressure, and RPP promoted by low intensity resistance training do not seem to differ between the ages and the body segments. So it doesn't matter how old they are, and it doesn't matter if you include the upper or the lower extremities with the blood flow restriction. The hemodynamics are relatively the same. Okay, the changes are within normal limits, however. Furthermore, the low-intensity BFR may be considered safe and viable for special populations, such as the elderly and cardiac patients, among others, because it promotes strength and hypertrophy without negatively changing the hemodynamic measures. Okay, this is the study that was sent out to the team prior to today's presentation. Blood flow restriction resistance exercises, a rehabilitation modality found in orthopedic surgery. They talk about within the article that if used, there needs to be some regulation and certainly some proper screening that, given the previous data that's been presented within this article, where there's actually a preservation of muscle mass, it actually has high potential to be beneficial for this patient population if we can safely administer it. So let's look here from Bond 2019. Studies have demonstrated that intermittent pneumatic compression reduces coagulation and enhances fibrinolysis. Fibrinolysis, and that's well supported by the sources that you can see there. Several studies have investigated the IPC as an alternative or adjunct to prophylaxis that demonstrate successful results for a number of post-surgical orthopedic patients, including those with total joint replacements. So essentially, the long story short is that this further provides the evidence of the fibrinolysis that the restriction occurs, or the pneumatic compression provides. Furthermore, when you're looking at the IPC as an alternative, which is the intermittent pneumatic compression, that even with the total joints, that this has shown to be beneficial. Okay, collective literature suggests that a proper prescription of BFR in the context of Virchow's triad, which would not heighten the risk of developing a VTE or a venous thrombosis or embolism. All right, so this was one of the big concerns that Taylor had mentioned actually to myself in the pre-questionnaire. So clinicians need to thoroughly screen for VTE signs and symptoms and be cognizant of each patient's VTE risk and factors. Okay, so that being said, how do we go about properly screening these patients? So obviously it would be probably a good idea that you have conducted some type of screening for their cardiovascular readiness to perform exercise in general, not talking about restriction here. And so if in question, yes, you can do a chart review. If you want a little bit more formality to it, you can always do a PAR-Q or a PAR-Q plus. This questionnaire has consistently been validated and consistently being updated from year to year. Okay, so before we actually look at the proper screening process that is conducted in the States, let's again look back at what has been done in KATSU training over the last 50 years or so. So you have a pooling of 13,000 subjects, and these questionnaires were sent out to the different facilities. And so essentially these are what is recommended by KATSU training to be conducted prior to or they're not all mandatory, but these are potential recommendations of things that can be done before the KATSU training takes place, right? And you can actually see that the checklist here, people gradually do the first couple really well, and then they kind of fade off, right? So they interview, they take blood pressure, hemodynamics, body weight, body composition they actually take, which is surprising, just given that it may not have a huge implication. You can get that really from their BMI as far as like stratifying the risk, and we'll talk more about that. These other things I was also quite I actually was questioning the fact that so few of these facilities took girth, and so few of them actually looked at or calculated the 1 RM, because we know that you need to be at if you're doing too high of an intensity with blood flow restriction training or KATSU training for that matter, that the hemodynamic response can actually increase to higher dangerous ranges. For instance, if you're pushing 80% of your 1 RM with restricted blood flow, that's when you're setting yourself up for failure and potentially a negative outcome. Additionally, the girth is usually recommended depending on the cuff that you're using. You can predict the proper pressure that would be put up to that, but they were taking the blood pressure. Perhaps they were doing it via Doppler. Okay, same studies. The only difference is now that they're asking these facilities whether they're doing this checklist, which is recommended for all subsequent trainings of KATSU training. And you can see that, again, they interview, they take the blood pressure, but only 75% of them do. Heart rate, pulse rate, again, gradually weaning off here, which is surprising and certainly not ideal. They're not, only like 25% of them are actually taking RPE. And then this is really startling, actually, the frequency of testing. So these clinics were doing it once a week, and actually at the most once a month, which people's hemodynamics, right, they change on a daily basis. And so I would say that it would be highly recommended that prior to using BFR, if you so choose to do so or have access to it, that you actually screen properly with that subsequent training list that was shown. And I'll give you further guidance on that as well, at least on every training bout. And if they were only training once a month, well, we know the effects were probably going to be minimal, if at all, given the fact that it's optimized with 2 to 3 times per week for consistent 6, 8, 10 weeks. Okay, so Nakajima in 2011 came up with a couple of screening tools or recommendations. So intake information, symptoms, history of disorder, lifestyle disorders, family, etc. So really trying to stratify properly stratify risk assessment and demonstrating whether these individuals are contraindicated, there were precautions, or that they were free to use KATSU training. Additionally, here are the indications, precautions, and contraindications that have been recommended. You can see that the red asterisk there demonstrates for males greater than 40, females greater than 50 require exercise tolerance testing. Not unlike what the ACSM guidelines also recommend by stratifying people into indicated precautions, contraindications as far as stratifying risks. So high blood pressures, so according to Nakajima in 2011, they said that as long as you were within the indicated range, you were safe to use blood flow restriction training. I think they were a little bit liberal in my opinion as far as the precaution range. I don't know if I'd feel, actually I know for a fact I wouldn't feel comfortable using BFR with someone whose systolic was 160 or higher, nor would their diastolic being above 90. Yeah, we'll talk more about how we can properly screen. I'm just showing you what has been proposed. Fasting blood glucose, again, it's a relatively high energy demanding, right? It's a metabolic stress that we're putting on these people. So we do want to make sure that if they are diabetic, they have sufficient stores of blood sugar to be able to perform the exercising the modality safely. Hyperlipidemia, you can see there. Obesity, again, as I mentioned, that BMI is can be a precaution and even a contraindication if they do fall into that obese range, that it is not wise to be putting further restriction on the vascular system. Okay, so this was the otherwise point scale or criteria that Nakajima then took that information and succinctly created. So you have the points across the top, 1, 2, 3, 4, all the way up to 5. You have the criteria, you have the column score shown, and you have the total score. And so this was modified from his paper, so I put it into a point. I kind of created it and succinctly put it into a single slide for you for your convenience. Should you want to use this point scale, this is the same point scale that is very similar to that is used within surgery when they're kind of stratifying people's risk of using tourniquets within surgery. So again, very similar criteria. I'm not going to go through all of it, but it's here for your reference should you want to pause the video and look through it. Okay, so Scott et al. In 2014 came up with this decision tree or algorithm for utilization of BFR. I would have to say that I feel like the authors were somewhat biased towards BFR as we kind of follow this tree down, right? So we'll go through the questions. Does the individual have a contraindication for BFR? If yes, consult a physician before implementing the BFR. If BFR is approved, is the individual mobile? If no, apply moderate BFR. So if yes, then could the individual tolerate loads of 20 to 40%, 1 RM? If no, combine low workload cycling, walking, and exercise with BFR. If yes, combine low load resistance training. And then finally, the decision is, could the individual tolerate high load resistance training? That being said, that it is best to use high load resistance training in combination with low load BFR rather than just low BFR alone, right? So they do show some really. So at the end of the day, right, if they are contraindicated and the physician says no, then you shouldn't use BFR, and then otherwise you should be using BFR. The only exception to that is that you use BFR with in a combination with a high load resistance training program. So yeah, I'd say that there's a high chance of bias with this. All right, so Lenicky in 2011, this is just more of a conclusive statement when it comes to the summary of safety and side effects. So in their systematic review, in conclusion, the current research on BFR training with respect to safety outcomes confirms early reports that BFR exercise, when used in controlled environments by trained and experienced personnel, provides a safe training alternative for most individuals regardless of age and training status. So I think that again, as I mentioned, it succinctly puts together or concludes what the data has. Okay, that being said, I was interested in this one study that was the only one known to date that I was able to find, at least. I'll throw that in there as a disclaimer. There may be others out there, but they specifically used inclusion criteria of hypertensive women. This was done in 2011 by Pinto et al. The methods are shown here. So randomized control crossover trial. They had 60 individual. They had 18 individuals, 60 years of age, 3 sessions. Each session randomized. Again with a crossover trial. So each individual went through each of these different trials or criteria. So in one instance, they didn't do any exercise. The next session, they may have done the BFR at 20% 1 RM, and then the strength at 65% 1 RM. And then the width of the cuff was 90 millimeters. Knee extension was the simple exercise that was used. The volume 3 times 10, 1 minute rest. Controls obviously did nothing. And then you can see the parameters there. The tempo was standardized, and so actually show that BFR at 20% 1 RM is comparable to people with hypertension, actually doing resistance training at 65% of 1 RM, which is the baseline minimum that you need, according to the research, to actually create a hypertrophy and strength effect. The diastolic blood pressure. So during resistance training, you can see that really a same effect here, where the the BFR was really no statistically significantly different from the 65% 1RM. Okay, cardiac output, same story. There was actually more stress on the cardiac on the heart for the over the 3 sets for the 65% 1RM versus the BFR. Okay, so finally, let's kind of look at the practical applications now that you know the safety and the side effects, how to properly screen for your individuals, and then also what the effects potentially are and the benefits that your patients can have. Okay, so we go back to some of the pooled data. So age, demographic. So this is essentially in Japan the patient demographics that of the people who are using BFR. It ranges from less than 19 to over 80 years of age, with the majority of the individuals being middle-aged. You can say that the occlusion pressure, intensity of training, number of sets, and duration of training unit remain unclear. However, the number of facilities, you can see that the different modes of exercise that have been used, everything from body weight to sports performance, walking, running, Pilates even is in there. And so you can see that BFR has been used, or Katsu training has been used really across these different modes. You can see the frequency is most common once a week, twice a week, and then 1 to 3 times monthly, which I haven't seen the outcomes of the 1 to 3 times monthly, but my suspicion based off the mechanisms and what we presented here is that it's more optimal to be doing multiple times a week. Okay, the duration, 20 to 30 minutes, is the maximum, should be the maximum usually. If we have the opportunity to actually go through the BFR occlusion, you'll understand why. However, you can see that significantly there's individual facilities who are actually doing it for much longer than that, which again increases the risk of having an event or a side effect, I guess is what I'm. Okay, Lenicky, you can see this was a paper that was presented early on in this presentation. You can see the citation there, the protocol that was used, and that the volume and the prescription is quite variable, in fact. So let me succinctly try and get across the parameters that are will potentially give you the biggest effect with your blood flow restriction utilization with the clinical population. So cuff application, proximal around the limb to be trained, right? As close as you can get to the joint line. If you're using a cuff that that has a tapered width, you want to use the widest portion and the most occlusive part of the cuff over the said artery. If it's in the upper extremity, that's going to be brachial. If it's in the lower extremity, it's going to be your femoral. Cuff type, so there's multiple different cuffs that have been thrown onto the market these days. However, in the medical setting, they need to be FDA approved. If you want to do more of the bro science in your personal gym, it's your own prerogative, and you can use your elastic wraps that are sold for what, $30 maybe on Amazon. Occlusion pressures, so this is going to be specific to the individual. So it's usually about 50 to 80% of the limb, depending if it's upper or lower extremity. This is why I highly recommend a FDA approved, because all of those you're able to standardize the cuff pressures, and some of them will even come with a Doppler. So for the lower extremity in particular, you can really monitor what the pressures are. And then the boxes just kind of highlight this for you. Okay, so type of exercise, single or multi-joint exercise, low load, 20 to 40% is optimal. Volume, 50 to 80 repetitions, right? It's metabolic demand, not mechanical tension input that we're putting, that is going to get these individuals the hyperbolus endorphin response and hormonal response that will allow for the adaptations. So you need high volume or high repetitions, short rest periods, frequency 2 to 3 times per week has shown to be superior to 4 to 5 times. For athletic populations, 2 to 4 times per week in combination with normal high load resistance training. Rest periods based off you can change up the rest period should you want to if you're really trying to really spike certain hormones, but usually typically it's short rest periods of 30 to 45 seconds. And then duration is 6 to 10 weeks, as we showed early on by Lenicky when he looked at the timelines. Again, this article, Scott et al. 2014, is hyperlinked within the references, so by all means you can. So Jeremy Lenicky also in his research group has been really helpful to us, where they've actually allowed us to consider the safe amount of pressures or predict the amount of pressures that we should be putting around a limb in order to restrict the blood flow to that 60% or greater threshold for the optimal effects. So 60% complete arterial occlusion pressures can be achieved in lower extremities with correlating pressures and dive circumference, meaning that even though if you don't have a pressure gauge, that if you take the width of the individual's limb, if you don't have a Doppler to be able to take the blood pressure of the individual in the lower extremity specifically, then what you can do is actually use the circumference measurement and then put the pressure of the cuff up to the said pressures, and that will get the individual to 60% occlusion or approximately thereof, so that they can their body will respond with to the modality. So factors for optimal pressure during the BFR. So other things that you do want to take into account is the width of the cuff, circumference of the limb as shown here, and then the arterial occlusion pressure of the limb. Essentially, at what pressure is the limb completely occluded? So those are other factors. All right, so types of cuff, there's many out there, right? So you have the tourniquets, inflatable cuffs, elastic knee wraps, narrow nylon cuffs are out there. Widths, you usually want, for the legs, you want to be 4.5 to 18.5 centimeters. Arms, a little bit smaller width. Again, the width of the cuff, particularly in the upper extremity, if they cover, the more muscle mass that they cover within the biceps, depending on the anthropometric measurements of the individual, may negate the effects, because we know the strength may be there, but we don't know what the effects are of those muscles directly underneath and proximal to the cuff. Okay, arms, so narrow cuffs, legs, wider cuffs, etc. Okay, so in regards to the scope of practice, the APTA has come out and said BFRT, or BFR training, is part of the professional scope of practice for physical therapists. And then each state legislation does hold the right, just like it does, for instance, like with dry needling, where they will come out and state whether practitioners within their state cannot otherwise perform such modality. The state of California does not put any restrictions on BFR. I expect that if it becomes more popular, that then they'll actually come out and put in an amendment to really specify. Should there be any restrictions. Okay, so FDA regulations. So this is a controversial point. So I've reached out to a number of competitors of BFR cuffs, and they have CEOs who are MDs have consistently stated that their products do not need to be Class 1 FDA approved. However, in speaking to the FDA directly just last week, that was as of April 2019, their representative said that given the fact that other pneumonic cuffs with the intended utilization of restricting blood flow for training outside of surgery have registered, that any other product that is stated to be a medical device or to be used in the medical industry or setting needs to also register. So I guess the long story short, if no company had registered their cuffs, then the FDA doesn't have a specific classification. However, because they do have the pneumatic tourniquets, which are used in surgery, but because companies have already registered, then that means every other product or competitor that has the same intended use needs to be registered. So you can't use cuffs in a medical setting if they're not FDA registered. I mean, people are doing it. I've seen it. However, it's highly, it's not recommended. Yeah. So billing, you bill under the standard physical therapy codes depending on the activity that the patient is performing, i.e. if you're doing, if you're using BFR with the stationary cycle, for instance, right? You do Therax or cardiorespiratory rehab or whatever you may be doing. And if you're doing it with NMES, you can bill it as neuro-re-ed, right? So it's based off the activity, not the actual modality of BFR. And that being said, there have been some business models that I've seen where the company will not bill BFR under the insurance, and the person will actually pay cash for BFR on the sessions that they're Okay, along with the practical and clinical applications is the RPE. So here you can see where they compared rate of perceived exertion of HIIT training to that of BFRT, and you can see that they actually parallel each other very well. That it will, so on the first couple sessions, right, the first two specifically in this study, that the RPE, or rate of perceived exertion, of BFR will actually be quite high. It won't be as high as your HIIT, but then gradually there will have the same decrease. And so it will take about 6 sessions for the individual to actually accommodate to the intensity of the metabolic demand that they're putting their body through. Okay, and then I do want to make a point, a very important point, in fact, because there is some misconception that high load resistance training it can be is like potentially less effective than that of the low load BFR, and that is not the case. Based off the data, right? So a systematic review that came out in 2017, review and meta-analysis. So when you're looking at strength adaptations, muscle strength adaptations, right? So that's not purely strength; it's actually like the adaptations of the tissue, the muscle strength, and the hypertrophy. That across the board, high load resistance training wins out when pooling the data. And so, put simply, if they can tolerate heavy, then give them heavy. That being said, it can be used as adjunct for athletes. Again, I alluded to the fact that because of the metabolic stress rather than the mechanical stress of the muscle, there's less tissue breakdown, thus shorter recovery times. And so when in season and needing to sustain or plateau performance for strength and hypertrophy, then BFR can be used as an adjunct in combination with high load resistance training, but consistently, if they can tolerate heavy, give them heavy. Okay, so low intensity BFR may increase muscle size and strength effects used when traditional high load training may be inappropriate or unattainable. Quantifiable muscle adaptations present quicker than traditional resistance training. Training greater than 6 weeks seems to offer greater returns in strength adaptations. BFR training has applicability to a range of populations who may seek to progress strength while reducing loads on the associated tissues, including muscular, tendinous, connective, and bony tissues. Early studies indicate that BFR may have positive. Okay, so here are 12 basic principle foundations that should be used with blood flow restriction training. This comes from Nakajima 2011. We've already seen this study. So number 1, confirm no contraindications. Hemodynamically unstable patients should not partake in BFR. Thrombotic disease patients are contraindicated. Explain pedicle hemorrhaging risk, which essentially is the risk that you may get bruising underneath the cuff if the individual is not otherwise used to the training. And based off the presentation in the slide before, or slides above, you know that the individuals that are going to be at higher risk for this are going to be middle-aged females who are sedentary and or untrained. Individualize the training not only to the pressures but the loads that are used. Build relationships and trust with your patients. Pay attention for faintness, dizziness, and lightheadedness. Caution should be used in your older individuals as well as your post-operative patients. Always have an AED available when anyone is exercising. So this is not specific to BFR. Short-term and low-intensity loads are going to provide you the best and safest outcomes. Contraindications, the patient is sick, right? So if they already have a fever, right, it's questionable whether they should be doing exercise alone, not only just restricting their blood flow, right? If unsure about medical conditions, seek specialist consult. Okay. Questions, comments, feedbacks, discussions. I know that's a lot of information. Please feel free to see the references below, as well as type any comments, questions, or concerns in the comment section below. Hope you enjoyed.